Good afternoon, and thank you for joining us today for our webinar, COVID-19 Vaccine and Kids with Food Allergy, What Parents Need to Know. I'm Jennifer Gerdts, Executive Director of Food Allergy Canada, and for those of you who are familiar with our organization, you know that we are a registered charity that focuses on providing education and support for those impacted by food allergy and acting as a national voice on key patient issues. I'd like to thank everyone for joining our fourth webinar on the COVID-19 vaccines with Friday's announcement from Health Canada authorizing the first vaccine for children aged 5 to 11 and vaccinations starting over the last few days. We wanted to bring together a panel of experts to answer your questions. Today's landscape looks very different than the last webinar. As of yesterday, according to the COVID-19 vaccine tracker, 83% of eligible Canadians have received at least one dose of the vaccine, and 79% of the eligible population is fully vaccinated. The data on new COVID cases reported from the Public Health Agency of Canada has indicated that the under 12 population accounts for 20% of the new COVID cases, while representing 12% of the population. At the same time, the conversation regarding children under 12 who catch COVID is they experience mild symptoms. So the challenge for parents is how to make sense out of the risk-benefit decision. And think, for those in the audience today, you're also thinking about how food allergy fits into this picture. Recognizing that all of us as parents want to make the best possible decision for our children, we've assembled a panel of experts from Health Canada, infectious disease, and allergy to help inform your decision on this important public health priority. Before I formally introduce our panelists, a couple of housekeeping notes, and we always like to start with a poll question to get a sense of where our audience is at. So first, note that this session is for informational purposes only and will not provide specific individual medical advice. Please talk to your doctor about any specific concerns or questions that you may have regarding your own health or the health of your child. Thank you to everyone for submitting their questions on registration. With over hundreds of questions received, we've synthesized them, and not surprisingly, there are very common themes which we will begin to tackle in today's session. Please feel free to use the chat box if you need clarification on some of the responses, and we would ask that you complete our post-webinar survey to identify unanswered or follow-on questions that may inform additional webinars. And lastly, know that the webinar will be recorded and shared on foodallergycanada.ca afterwards. So let's put up our poll question to kick off this session. So we'd like our viewing audience to answer this question. Do you have the information needed to confidently make a decision on your 5 to 11-year-old child getting the COVID-19 vaccine? If you could take a moment to make a selection. All right, let's see what results we have coming up.
So what we're seeing as the results, 22% said yes, 41% no, and 37% unsure.
Great, thank you very much. All right, so let's have our panelists turn on their webcams, and I'd like to introduce our experts for today. All right, thank you everyone for joining us. First off, I'd like to introduce Dr. Celia Lourenco. My apologies, Dr. Lourenco. Dr. Lourenco is from Health Canada, holds a PhD in pharmacology, and has been the Director General of the Biologic and Radiopharmaceutical Drug Directorate of the Health Products and Food Branch of Health Canada since November 2018. This directorate is the federal regulatory authority responsible for regulating a variety of drug products for the Canadian market, including vaccine. Dr. Lourenco is also the co-chair of the COVID-19 working group of the International Coalition of Medicines Regulatory Authorities. Welcome, Dr. Lourenco. Dr. Zain Chagla is a specialist in infectious disease and a familiar face for our mini webinars that we've done on this topic. He is a consultant physician at St. Joseph Hospital and Hamilton Health Sciences in Ontario. He's also the Associate Professor of Medicine at McMaster University. I know that many of you have either heard or read about Dr. Chagla through the media because he is sought after to provide his expertise and perspectives on COVID-19. We're also very fortunate to have with us Dr. Julia Upton. Dr. Upton is on staff at the Hospital for Sick Children in the Immunology and Allergy Department and is the Associate Professor in the Department of Pediatrics at the University of Toronto. She is the past section chair of the Anaphylaxis and Food Allergy section of the Canadian Society of Allergy and Clinical Immunology and is a member of our Healthcare Advisory Board. She's also co-author on the CSACI statement on allergy management regarding the COVID-19 vaccine. So we've assembled some wonderful experts here today, and based upon the submitted questions that we received, here's what we're going to do. We're going to tackle the topics in this order. We're going to talk about what vaccines are available and have Dr. Lourenco walk us through some of the process for the approval and touch on their safety and efficacy. We're going to get Dr. Upton to really lead us through a focused conversation on and questions around the safety of the vaccines if you're managing allergy. We're then going to turn to Dr. Chagla, who's going to really walk us through some of the side effects and give us a deeper understanding on what are the side effects and adverse reactions specific to children. And then we're going to close on a discussion that is around the risk benefit of getting the vaccine. I do, though, want to start with the question that was the most dominant, the most commonly received question from our viewing audience right off the top. And that question goes to Dr. Julia Upton. And it really is, the question is the vaccine safe for those with food allergy? Dr. Upton?
Thank you so much for inviting me today. So yes, the vaccine is safe for children with food allergy and people with food allergy. In the way the vaccine is given, everybody waits for 15 minutes after the vaccination to be under supervision during that time that there could be, that has the highest chance of a reaction. And so for someone with food allergy, that same safety precaution exists. There's no additional safety precautions, meaning that there's no need for pre-testing, and there's no need for an extended monitoring period for people with food allergy.
Great. Okay. So, with that in place as the most pressing question, I'd now like to move to what actually has been approved and what is the approval process. So, Dr. Lourenco, can you walk our audience through what has been approved for the 5 to 11-year-old audience?
Sure. So we have approved the Pfizer, you may have heard the Pfizer Comirnaty vaccine for children 5 to 11 years of age. The approval was issued last Friday, as I'm sure many of you have heard. And now the vaccine is being rolled out in the country, as you mentioned earlier in your opening remarks. We looked at a series of clinical trials that were done in children 5 to 11 years of age, starting with a phase 1 clinical trial in a small group of children that looked at different dose levels, 20 micrograms, 30, 20, and 10 microgram dose levels. And it showed that the 10 microgram dose was appropriate, safe, and could be moved on to a larger clinical trial that was subsequently conducted in about 4,600 children, ages 5 to 11. It was a trial that tested the vaccine in a group of about 3,100 patients, and then the vaccine in 3,100 patients and a placebo group, meaning a group of patients that did not receive the vaccine, they received a placebo instead. That was about 1,500. And so those children were followed for about 3 months. And what was shown at the end of 3 months after receiving 2 doses of the vaccine, 3 weeks apart, the vaccine was both efficacious with an efficacy of 90.7%, which is really fantastic. We've seen really great efficacy for the mRNA vaccines, and that was again demonstrated in this age group as well. And the safety profile was also very good. No new safety issues were identified, just the usual reactivity issues that we see with the vaccine, local site pain, local site reaction, maybe some fatigue and headache were reported in the clinical trials, but no issues of myocarditis, for example, were identified in the clinical trials. So based on that data, we concluded that the vaccine is safe and effective.
Okay, so I think there is a great infographic that walks Canadians through the process that Health Canada goes through. And I think you've described it well, but I think it would be great if we could just pop up that slide so that people can kind of put Dr. Lourenco's context or comments into this context. So maybe if you want to just kind of high level walk through this, Dr. Lourenco, that would be great.
Sure. So for the mRNA vaccines, actually, this is a platform that's been under exploration for a long time, for at least a decade, in the area of cancer vaccines. But as soon as the pandemic hit, scientists pivoted and started using the mRNA platform to look at developing a vaccine for COVID-19. So lab and animal studies were conducted to see if there was any initial evidence of the vaccine potentially working for COVID-19, and based on those results, they moved on to conducting studies in a small number of volunteers. As I mentioned earlier, we start off with what we call phase 1 clinical trials that assesses the vaccine in a smaller number of volunteers, usually 10, in the range of 10 to 100 volunteers, that look at different doses of the vaccine and mainly looking at safety of the different doses. And then and also some initial sort of immunogenicity, or how the vaccine, whether the vaccine provokes an immune response in that early phase 1 trial. Then, if based on those results, we move on to phase 2 trials, which enroll a larger number of volunteers that further explore both the safety as well as the efficacy of a number of doses of the vaccine. And based on those results, usually a single dose is selected then to move on to a phase 3 clinical trial that enrolls thousands of volunteers. So I mentioned earlier that for the 5 to 11 years of old trials, we enrolled 4,600 subjects were enrolled in those trials. So that is a trial that then confirms the efficacy and safety of the vaccine.
Okay. Terrific. And then that then turns into the approval process. Stuff is purchased, we have distribution. Anyways, I do think that this is a chart that if people really want to go back and understand, you know, the role of Health Canada and what they're doing in the approval process, this is a really great way to take a look at it. So know that this is going to be in the recorded version, and if you want to pause and look at it later when you receive that, you can look at it in more detail. I would like to ask Dr. Chagla, when it comes to this, so we've got a dose that's been approved. How is that dose different between adult and child? So, you know, because we had an approved dose for adults, how is it different with children?
Yeah, so I think as Dr. Lourenco had mentioned, you know, the 10 microgram dose is the one that has been approved for children. And, you know, there's been a lot of confusion out there, you know, as other drugs that we give between adults and children are different based on weight-based dosing. You know, why can we make a kind of solid statement for one single dose amongst kids of all ages as compared to, you know, a 5-year-old who's much smaller and typically than a 12-year-old or 11 and, you know, 6-month-year-old. So, you know, this really goes back to the immunology of these vaccines, right? And what's been studied in these trials. And so they looked very closely at this 10 microgram dose, as well as 20 microgram and 30 microgram dose, and saw, again, immunologic responses being very similar in 5 to just before 12-year-olds as compared to 12 to 15-year-olds who got the full 30 microgram dose, or what would be the adult dose, basically. So, you know, I think people don't necessarily have to worry about the body size of their children in the standpoint of we have immunologic data to suggest their immune system acts exactly how an adult would act in response to these vaccines. The other, you know, point is yeah, so I'm sorry, that is really the major piece here in terms of that dosing. So, you know, again, this is a research dose, and sorry, the other point I was trying to make is, you know, that the post hoc analysis around the efficacy, so how well these kids did after their immunologic responses, shows a 90.7% reduction in symptomatic COVID-19 amongst these children who got the 10 microgram dose. So, you know, as we remember from our original Pfizer trials, we were talking about 90 to 95% efficacy. This is well within that ballpark of efficacy in the trial. So we can see that the immunologic responses are the same. And again, the efficacy is the same amongst these children. So again, no concerns here about a very small 5-year-old versus a very large 11 and 8-month-year-old, that getting the same dose is applicable as they were all enrolled in this trial.
Okay, terrific. Okay, so we're going to come back to that question around dose when we get into some of the long-term effects, because there's been some questions, of course, around puberty and that sort of thing. So I'm going to leave that for right now, because I do want to make sure we've got some enough time to really dig into the questions specific to food allergy. Our viewing audience, most are familiar with food allergy. They have a greater familiarity with the topic of anaphylaxis, and and there has been some history in the past where the flu vaccine, as an example, was not recommended. That's changed, of course, for those with egg allergy, but I would like to get Dr. Upton's input here in terms of what is the guidance from the experts in food allergy, so from the Canadian Society of Allergy and Clinical Immunology, when it comes to the vaccine and people with food allergy. Is it considered safe for those with severe food allergy? Let's talk about that.
Yes, so I agree. That's one of the main focuses for us, especially with Food Allergy Canada. And so, as we mentioned off the top, the food allergy is not considered an additional risk. It doesn't require pre-testing, and it doesn't require an extended monitoring period. So, people with food allergy can get the vaccine in the routine locations, in the routine way, with the routine monitoring, and without any particular testing or anything like that before they go.
Okay. Now, what about let's talk about the other allergies, environmental allergies. Is there any reason to be concerned with environmental allergies?
So environmental allergies would also be the same as sort of the general population. So someone with an environmental allergy would also not need any testing beforehand. They can get the vaccine in the regular way with that 15-minute wait. Okay,
I'm going to, we got a lot of different questions on this, Dr. Upton, so I'm going to go through them and you can give me yes, no, no, okay? Perfect. What about, is sulfa allergy an issue?
No.
What about?
So when I say no, and I will just say that when I say no, I mean everyone, that indication or that concern is not an additional concern beyond the way that we're managing the vaccine for the general population.
Okay, penicillin. Okay. If you got a penicillin allergy, what about celiac?
So, for penicillin, I will just split that separately into how the National Advisory Committee for Vaccination and for Immunization has managed drug allergy is they have made a distinction between an oral reaction, like a reaction to an oral med, and a reaction to an intravenous medication or an injected medication. And so when we are thinking of drug allergies, we do want to make that distinction, because what NACI has recommended is that anyone with a reaction to, with a severe allergic reaction to an injected agent or an intravenous agent or an intramuscular agent is treated slightly differently, where there's still no testing required in advance. But because they've had a reaction to something given like that before, they do want them to wait 30 minutes after the vaccine. And I think we can elaborate on that further, but the drugs, we just need to be cautious to make that distinction.
Okay, what about eczema and multiple food allergies? If you have multiple food allergies, okay, and what about if you're undergoing OIT, oral immunotherapy? Some in our audience may be going through oral immunotherapy. Does that change anything?
So that's a great question, and there isn't really studies on this, but just to reduce the possibility of being confused between the possible side effects of the vaccine and the possible side effects of immunotherapy, the advice is to separate those two out a little bit, because you can imagine if I took my immunotherapy and I got my vaccine at the same time, and now, a few hours later I have hives, perhaps, it might be confusing to figure that out. Or if I was to get a fever from the vaccine, then that might affect my tolerance that day of my immunotherapy. So really more from a almost common sense kind of point of view, or to minimize confusion, we are recommending to separate out the immunotherapy from the vaccine.
Okay, so then let's talk about this in another way, because I think that many of the questions I was going to ask you is going to like, no, it's fine. But let's ask this in a different way. What does put you at higher risk of reacting?
So the things that on history, the things that would put you at higher risk of having an allergic reaction would be an allergic reaction to the first dose of the COVID-19 vaccine. So that definitely requires a more fulsome discussion. If there was a severe, immediate allergic reaction to the first dose or a subsequent dose of the COVID-19 vaccine, then we do have to think about the severity of that reaction and the plans moving forward. And so that would be what we call a risk-benefit discussion. People that have reacted to a prior dose of the COVID-19 vaccine, we are recommending they do see an allergist to understand that reaction and discuss the risks and benefits, and to consider how that vaccine can be given safely. I will say that we now know this part in the pandemic, we now know that the vast majority of people, even those who have had severe immediate allergic reaction to a prior dose of the COVID-19 vaccine, including anaphylaxis, can actually tolerate that next dose. And so it has been moved from a contraindication, which just means, a sort of a strongly worded don't get it, into a precaution. And so that's because so many people that have had an allergic reaction to a prior dose tolerate the next dose. And why is that? I think part of it is that we don't completely understand the risk factors for allergic reaction. It's rare to have an allergic reaction to these vaccines, but also that many allergic reactions to vaccines can be due to another cause, and such as people can faint from the reaction. People can have other reasons that really, really look like an allergic reaction that maybe weren't. And so the bottom line is reaction to the vaccine itself does require an allergy consultation to understand what's the best way forward. Other than that, the people who have been put into a higher risk category where we're advising to wait 30 minutes after the vaccine would be people who've had a prior reaction to an injectable agent, like I discussed, as well as people who have a suspected but unproven reaction to a component of the vaccine. And so in popular culture, we hear a lot about PEG allergies. PEG allergies are likely to be very, very rare, but the advice is that if you are suspected to be allergic to PEG, but it isn't proven, then we can still go ahead and give the vaccine, no testing, but with a 30-minute observation time for that. Whereas if you have a proven allergy to the vaccine or to a component of the vaccine, then that requires an allergy assessment.
Okay, great. Okay, so Dr. Chagla, when it comes to reacting to components or ingredients of the vaccine, are there any food allergens in the vaccine itself?
No. So and maybe is this the time to show the ingredient list, because that might be helpful to go through it.
We can pull that up, yeah. If our back end supporters can get that pulled up, that would be great. And while we're waiting for that, Julia, there was a couple of questions, or Dr. Upton, a couple of questions that came in for clarification. People didn't hear the response on the, is eczema a reason not to get the vaccine, as well as if you could quickly respond to how long to separate the vaccine from an OIT updosing.
Great, thank you. So, eczema is not a reason to not get the vaccine. Okay. And the separation, so there isn't an answer that's science-based to tell you how long to wait between oral immunotherapy and the vaccine. But what the Canadian Society of Allergy and Clinical Immunology has recommended is 72 hours, and really that's just just to be, just to avoid confusion, and also to understand it is quite common to have a fever after the vaccine. And anyone that's on oral immunotherapy in this webinar may know that sometimes we do give advice around fever and dosing, and so that is definitely something to speak to your allergist about, the timing separation. But on the CCCI website they recommend 72 hours.
Terrific. Okay, Dr. Chegla, walk us through the ingredients and do some interpretation for us here.
Yeah, absolutely. So these are obviously big scientific names, although some of them are pretty common to us, right? So this is just where the importance. These are actually pretty clean vaccines. They're the ingredients are things that we find that we're exposed to on a daily basis. And again, it really is the mRNA component, which is nucleic acids, which are a part of our normal body that we make and have made since the day we were born, or the day we were conceived. And really this lipid nanoparticle, so this fat particle that suspends the mRNA and keeps it stable. And we talk about these long compounds of lipids or fats, basically. So the compound noted, the first two compounds there, which I'm not going to pronounce because I'm going to butcher them, but these are compounds that are used to stabilize, and you see polyethylene glycol, as Dr. Upton had mentioned, as part of one of the ingredients there. Again, phosphocholine is another lipid molecule, and again, all of these are fats that are used to maintain that capsule around the mRNA. Cholesterol, which is a part of all of our cells, where people should not be allergic, and the rest of the ingredients: sodium chloride, which is just salt, again, just as in the salt water, the solution; sucrose, which is just sugar; water for injection. The difference with the pediatric vaccine is the inclusion of this tromethamine compound, which is a stabilizer. This also has a small potential for allergy. Tromethamine is a part of certain antibiotics and not penicillins or not sulfa drugs, so a very specific antibiotic called fosfomycin, and sometimes found in contrast solutions for patients who have to undergo CAT scans and that type of thing. This is also a component of the Moderna vaccine and has been part of the compounds in the Moderna vaccine in that sense. So, again, most of these are, these 9 ingredients basically are normal components of our body cells. The two of interest are polyethylene glycol, as noted, and tromethamine, which is slightly different than the adult Pfizer vaccine, which does not have this ingredient. But again, an allergy to tromethamine is incredibly rare. If you do have an allergy to IV contrast, then it may be one thing to talk to your family doctor or prescriber about before getting the vaccine. But again, these are not present in the vast majority of the population and not cross-reacted with other antibiotic or food allergies in that sense.
Okay, great. Okay, thank you, Dr. Chegla. So now one last thing before we move on to the more of the background on kind of side effects. For people that are considering the flu vaccine and the COVID-19 vaccine, can they get them together? Dr. Chegla, do you have a perspective?
Yeah, sure. I can go through it. So the vast majority of adult data has come out saying, the co-administration of vaccines with the COVID-19 vaccine are safe, and in adults and those over the age of 12, it's recommended that there's no spacing interval between the two vaccines, the COVID-19 vaccine and other vaccines like the influenza vaccine. For children, just as we are still doing kind of the phase 4 surveillance, so the monitoring for adverse reactions in children that are rare and unexpected, not that they will occur, but just to keep things as clear as possible, there is a recommendation for the National Advisory Committee on Vaccines to space out the flu vaccine and the COVID-19 vaccine by about 2 weeks. And the reasoning for this isn't that they are dangerous, mixed together. They likely are not. The issue is that there is a very rare side effect that shows up. We want to be able to attribute it to which vaccine caused it, and not necessarily get that confused in everything. So again, this is a precautionary note, and likely as the data accumulates that the side effect profile is safe, and as it's already being shown to, but that rare adverse reactions are identified. you will likely be a vaccine that we can co-administer with other vaccines fairly easily, and again, and drop this warning outside of this early phase.
Great. Okay. Okay, so let's move on to side effects. Okay, and again, we want to put adverse reactions, side effects, and the severity of those reactions into context for this 5 to 11-year-old crowd, and then ask ourselves, is that any different with someone who has a history of food allergy or anaphylaxis? So Dr. Chagla, walk us through the typical side effects that were experienced or have been experienced in children with this vaccine.
Yeah, absolutely. So looking at the clinical trials, the 3 major side effects and a few minor side effects that were noted. Pain at the injection site is pretty common. About 75% of kids experience it. Interestingly, about a third of kids who get the placebo also experience it, which may be related more to the injection than it is actually to the drug. Swelling at the site of injection, again, more people who in the drug than the placebo experienced it. And again, that may be related again just to the immune response happening in the shoulder, which is exactly what's supposed to happen. Similarly, redness and rashes at the injection site have been noted. All of these are self-resolving, but do occur at a higher frequency than the placebo group. The other kind of major side effects that were noted: fever, a little bit higher, about 3 to 7% of kids. Fatigue, about a third of kids, although a lot in the placebo group also had fatigue, which may be more of an indication of the world we live in as compared to the vaccine, but slightly more in the vaccine than in the placebo group. Headaches, which were about the same in both groups. Chills and vomiting and diarrhea, muscle pain, small percentages under 10%, and joint pain, again, under 5% of kids. The one adverse reaction that has been monitored for and is the one of note that we are continually surveilling in the real life data is the risk of myocarditis. And amongst the 4,000 individuals who were enrolled in the clinical trial for children, there was not one individual that did have myocarditis. And so at least in this small trial, we are seeing that it's not as much of an issue, although again, this is something that has to be monitored for as we get to 10,000 and 100,000 doses in terms of if it does show up in small numbers amongst children, and if there are particular children, it shows up with more in that context. So again, all the adverse reactions were mild, self-limited. There were very minimal serious adverse reactions noted in the study, and most of these would be expected for a vaccine that's triggering your immune system in terms of redness and fever and swelling, as that's the sign that your immune system is actually reacting to this vaccine appropriately and making a response.
Okay, and with myocarditis, tell us what that is, okay, and who's most at risk? Because I hear you that it hasn't been something that you've seen in the trials, but like just help our audience understand what that is.
Absolutely. So so this is a rare reaction that is likely associated with the mRNA vaccines, both the Pfizer and Moderna vaccines, that's been seen in adults and teenagers. This is myocarditis is a fancy word that just kind of means inflammation of the heart. And pericarditis is inflammation around the sac of the heart, and so they're interlinked. This is a reaction that can occur with COVID-19 as well, and in fact is at a higher rate of people who get natural COVID-19 that do suffer from it, especially some of the seriously ill individuals. This can evolve within the first 3 to 4 weeks after vaccine, often very early, can present as chest pain, shortness of breath, after the vaccine, and has led to a number of children being hospitalized. We think the most recent estimates are about 100 in a million, although the highest risk group seems to be those teenagers, particularly male teenagers between the age of 12 and 17, where they seem to have the highest rate amongst the population, although it's been seen in all ages. The other part is noted more on the second dose than the first dose, and again, it is does occur on the first dose, but significantly more on the second dose amongst teenagers. And so, the estimates there of 100 in a million or 1 in 10,000, is certainly reassuring for the vast majority of patients. But it is something we do have to monitor for as we start administering into the 10,000, 100,000 range if this signal does show up in that age group. So again, this is the one thing that is being monitored for parents of kids. Certainly if they do experience those symptoms, they should seek medical attention. But at least from the experience from 12 to 17-year-old children, it is still a very rare side effect, even in the context of it being the highest risk group.
Okay, so Dr. Lourenco, when you think about the adverse events, and you actually, I mean, the U.S. is well ahead of us in terms of the number of doses that have been administered in this. How does Health Canada take a look past that clinical trial and that data that you've used to approve it? How does that data, that's real life data, come back to Health Canada and inform kind of like how is it used?
Absolutely. So we continue to monitor very closely the safety of the vaccine once it's launched onto the market. So both the manufacturer as well as healthcare professionals in Canada report adverse events either through the Public Health Agency or directly to Health Canada. So manufacturers are required to report any adverse reaction that they become aware of, any serious adverse reaction directly to Health Canada. And for these vaccines, we have actually implemented a risk management plan where manufacturers need to provide an update to us on a monthly basis to look at what that safety picture looks like and how it's evolving. The Public Health Agency looks at the adverse reactions reported by healthcare professionals through the provincial public health units, and Health Canada and Public Health Agency work very closely together to assess that safety profile as it's evolving. And we also work very closely with our international regulatory partners. You mentioned the US, so the US Food and Drug Administration. We have very frequent international meetings with these regulators to get information from their context as well. So we're aware that in the US, for example, there have been 3 million doses so far administered for the mRNA vaccine, for Pfizer vaccine in children 5 to 11, and no myocarditis signal so far. So I think it's still early days, obviously, it's just the first dose. And as Dr. Shagla said before, we tend to see it more after the second dose and mainly more in males versus females. So we'll see what that picture looks like, but at least this initial data coming out of the US of 3 million doses of one dose is encouraging that so far there doesn't seem to be an issue in this age range.
Okay, terrific. So Dr. Upton, like with what we're talking about with adverse events, does the picture look any different for those that are managing food allergy?
So the adverse events in terms of getting the vaccine itself, as we mentioned, we're really treating people the same as general population if you have food allergies. And just some things maybe I wanted to clarify. I had lumped together for the immunotherapy question, I lumped together the injected immunotherapy with oral immunotherapy as well as sublingual immunotherapy. Just to be clear, it's the injected immunotherapy that we would typically say 72 hours. And then most of us are saying don't up-dose oral immunotherapy for 72 hours. But your allergist might be okay with you taking it that day. Most people under oral immunotherapy have very good access to their allergist, and it is quite individualized. And so I do suggest to discuss that with your allergist. Whereas the sublingual immunotherapy is so low risk of a systemic allergic reaction, your allergist may be comfortable with you continuing. So sorry, I had lumped them all together.
Right,
and I
no,
didn't
that's
want
fine.
to,
well, thank you for clarifying that.
So
Okay,
because for food allergy, certainly that's a concern. I also, when we were speaking of the atopic disease, we mentioned atopic dermatitis. I do want to take a minute to talk about asthma. I don't know if that's the time, if this is the time,
sure.
because is this a good time for that?
Yep.
So for asthma, I think it is just really important to highlight asthma, because really a strong vaccination strategy and strong vaccination uptake is really important for the management of asthma. And so COVID-19 vaccine is no different. We definitely want people with asthma to get this vaccine. And so the one concern there would just be that if someone was undergoing current symptoms of an asthma attack or current symptoms of asthma that is not under control, then that wouldn't be the exact time to get the vaccine. And so we would want that acute illness and that current illness and that current asthma to be controlled before we get the COVID-19 vaccine. Plus, it would cause trouble. You might even fail the COVID screening, if you have a lot of shortness of breath and cough and wheezing. So we would want that acute illness to be settled and under control to get the vaccine. And it is really important from asthma exacerbation point of view to get the recommended vaccines. And so I just wanted to highlight that because it can be quite common, with our food allergic.
Right. No, that's really important because there are, of course, people in our audience that have a number of comorbidities, not just food allergy. And to that end, as we talk about side effects and wanting to avoid kind of side effects, one of the questions we've received is, is there advice on giving Benadryl a few hours prior to a vaccine to minimize reactions? Maybe Dr. Upton, you can speak to that.
That's a great question. As a general rule, I would not recommend that somebody with food allergies requires antihistamines prior to the vaccination. So I think the use of antihistamines would be a special circumstance, and it's not routinely advised. It's more in the setting when people have had one of the things we really like about the allergy specialty in 2021, 2022 is that we are really in a position where we can help people get those doses even if they had a reaction. And right. So when we're dealing with those situations where someone has had a reaction to a prior COVID-19 vaccine, then there's many management strategies that can come into play when we're discussing the risks and benefits and the approaches for vaccination. So in summary, routine pre-medication with antihistamines for somebody with food allergy is not required. There may be special circumstances that it's considered.
Okay, so Dr. Chagla, do you want to, we had another question that came in on this topic now around whether Tylenol or Advil should be given before. What's the general perspective from the infectious disease aspect?
Yeah, so I mean, this is a bit of a controversial subject. I think some people are very used to taking a dose of an anti-inflammatory before to reduce their symptoms. There's a little bit of data from things like influenza vaccine where, our body's ability to make a fever, even though it's uncomfortable and makes us feel unwell, is actually probably not harmful for us. In fact, maybe beneficial for our immune response. Potentially taking it might blunt the immune response a little bit, but nothing has really been shown with these vaccines. They seem to be very immunologic from the side effect profile. So, the children, at least in the Pfizer trial, at least some of them did take antipyretics or these drugs basically afterwards in that sense. So, I think it's not unreasonable to consider it before if you're actually want to wait and consider it afterwards. If you're feeling uncomfortable once those immune reactions start, that's also reasonable too. But if you want to wait it out and be reassured that most of these symptoms are benign and will likely just pass within a day or two, and just with rest and taking it easy are probably more efficacious, then that's fine too. So I wouldn't say anything for or against, but it might be a bit reasonable to consider delaying it until you develop side effects in terms of fever or feeling unwell, rather than necessarily doing it as a prophylactic strategy beforehand.
I guess the key message here is best to be healthy when you're going in so that the symptoms don't get confused with
and maybe take some time the next day or two to just take it easy in terms of not booking a lot if you're having side effects.
That's a good idea. That's a great idea. Okay, let's move on to the conversation around long-term side effects, because this parents are concerned, right? They're responsible for these young children of theirs, and they want to do what's right. And so there has been conversation around potential long-term side effects given their developing bodies. So, is this an issue that parents need to have top of mind, Dr. Chegla? What do we know about the long-term side effects, and how do we think about this topic?
Yeah, absolutely. And again, this goes back to the initial conversation we had at the beginning around kind of immunology and how these drugs work. They're very different than other drugs, right? You take a medication for 2 months, 3 months. Yeah, there may be long-term risks. You take chemotherapy, there may be long-term risks. But remember, vaccines are very short-acting compounds. Their job is to, stimulate the immune system, degrade, and let the immune response do its work. And so, absolutely, there needs to be surveillance for long-term side effects. But for the most part, most vaccines, if the side effects do show up, they show up early, because that's when the vaccine is active in one system. That's when the responses are there to viral vaccine proteins and compounds. It's not late. And when the vaccine is degraded, all that's left is the immune response, which is the memory. And certainly, at least from the experience with the Pfizer, Moderna, even AstraZeneca and Janssen vaccines, again, the side effect profile, including some of the rare side effects that have occurred from the vaccine, have largely been within the first 4 to 5 weeks of administration, as compared to 6 months, a year, 5 years later, in that sense, where, given the cohort that many of us that got vaccinated in healthcare about, a year ago, we're still not seeing any long-term side effects showing up in that cohort.
Okay. Now, what about this question of having the childhood vaccines at the same time as the COVID ones? Is there any issues? Because we've talked about flu vaccine, but it seems like people are also managing childhood vaccines. What's the thinking on that?
Or, there's a little bit of a worry about giving children too many vaccines at once. Right. Remember, our measles shot is actually measles, mumps, and rubella. So every time your kid gets their measles shots, they're getting 3 vaccines. Our tetanus shot is tetanus, diphtheria, acellular pertussis. So again, they're getting 3, vaccines all at once. We do Hep A and Hep B vaccine together. So, temporarily, again, that spacing of vaccines is mainly there, not from the sense of overwhelming the immune system or anything. It's just to make sure that if there are rare side effects, we can really distinguish which vaccine it comes from. But, at the end of the day, kids and adults receive many vaccines at the same time. Kids as babies, as they're going through their primary series, are receiving, 6 vaccines at a given time throughout the combined molecule. So, again, there shouldn't be a worry about multiple childhood vaccines at the same time. Children receive multiple vaccines at the same time normally. And again, as long as they are in good condition to receive the vaccines, there shouldn't be any concerns in that sense.
Okay. Again, sorry, I want to go back to the long-term effects piece. With the 11, 12-year-old, okay, like we have had, again, because it factors in some of the concerns around they're in puberty, is there, the dosing piece? I want you to just restate, kind of confirm the thinking around, if I've got an 11-year-old who the first dose is when they're 11, the second dose is when they're 12, like, how do we need to be thinking about that on that subject? And Dr. Chegla, maybe you can take that as well.
Yeah, absolutely. Look, I think we, again, have to look at the clinical trials and what they showed. And again, there were 11 and, 7-month-year-olds in the clinical trial for 5 to 11-year-olds, which all showed this uniform good response to the 10 microgram dose and actually the protection that was shown. And similarly, we have 12 to 6 to 15-year-olds and 15 to 11 months that were included in the adolescent trial that got the 30 microgram dose and had similar immune responses and 95+ protection against COVID-19 in those trials. So again, if a child transitions from 11 and 9 months or 10 months to 12 years old during their vaccine series, it's fine to then consider going to the higher dose. But I think, again, it shouldn't be something to fret about too much. Both of them do show immunologic clinical data in terms of safety and efficacy in those groups. And again, we look to our clinical trials to make sure that we're rational in terms of how we offer these, and that we show that we have data in these age groups. So again, fixating on the dose, is not necessarily going to be the big thing. There are going to be a small number of children that transition from one dose to another dose as they go through, again, 18 and 8 months to, or 18 and 10 months to, 11 and 10 months to 12 years old during the vaccine series. But the vast majority of children, again, can be classified by their age into their dose.
Okay, great. Okay, let's move into the conversation around the risk-benefit discussion. So, the narrative today is, seemingly that the symptoms that children under 12, that what they experience if they get COVID is that it is a mild, issue. And so, when you combine that with the rate of vaccination across the Canadian population being over 75%, it's hard for parents to kind of go, well, like, help me measure the risk benefit, because my child is unlikely to get a severe illness. It's with what you've all of you have been talking about today is that there are side effects, but the evidence of adverse reactions is very, very low to none at all in the case of the myocarditis. But how would you advise parents thinking about the risk benefit? And Dr. Lourenco, I'm going to turn to you first on this question from a Health Canada perspective. What do you think parents should be considering when they're thinking about this decision?
Sure. It's true that as we look at the evidence through the pandemic and which populations are most impacted, it tends to be older age groups. That said, though, children have still been impacted by COVID during the pandemic. There have been over 120,000 cases of COVID in children 5 to 11 in Canada. And of those, there have been over 300 hospitalizations, including almost 50 ICU admissions to date, and unfortunately 2 deaths in that age category. It is less than when you compare it to older individuals, but nonetheless, the risk is still there. And then there's the other impacts on children, the ability to get together with their friends, have play groups and birthday parties, and go back to more of a normal life that they haven't been able to have over the past year. I think that's also a very significant impact that we need to take into account. And then finally, also the fact that children can still pass on the virus to others who may be more vulnerable to the virus. So I think all of those considerations are what we took into account, and then looking, of course, at the safety profile of the vaccine in the clinical trials and the efficacy that was demonstrated and immunogenicity, high immunogenicity that was demonstrated. For us, the benefits clearly outweighed the risks. We'll continue to obviously monitor this very closely, as I mentioned, in the post-market, and we'll take action if needed. But from Health Canada perspective, we do recommend the vaccine in this age range.
Okay, great, thank you. Dr. Chagla, I'm going to ask you the same question. I'm also going to ask you, because there was another question that came in on this, is if your child's had COVID, why do you need to get vaccinated? So if you can include that as part of your comments on this risk-benefit question, that would be great.
Yeah, absolutely. So, I mean, I think there's some very great points that were just made, and again, this is a virus we're going to all have to live with for some time. We know these vaccines are safe. We know our 11-year-olds are going to turn into 12-year-olds who are going to turn into 18-year-olds where they're going to need protection against this virus. And so, it's important to realize that, especially as kids get back to normal, get back to school, get back to sports, get back to activities, get back to hanging out with friends, they're going to be at higher risk of acquiring this virus. Yes, the clinical severity of it is less in kids, but it doesn't necessarily negate the fact that kids can get sick, kids can get hospitalized. Kids can suffer complications like multi-system inflammatory syndrome, which is a rare complication that causes an autoimmune reaction in children. And children can circulate and can develop complications that are prolonged, like anosmia or long COVID. And so, again, there are still multiple reasons where the risk benefit favors benefit in children. There's even more benefit in those children who have underlying health conditions, even as simple as asthma or diabetes or obesity, where we know that the representation of children is even higher, and those children absolutely need to be protected. And again, vaccinating your children also helps protect those other vulnerable children out there in their schools and in their societies. Natural immunity is real, and we do know that post-infection immunity does exist, and it does give children some protection over time. We are still seeing, though, at least in adult data, that vaccine immunity plus natural immunity, so-called hybrid immunity, offers the highest amount of protection. And again, this virus keeps changing. Every night we go to sleep, every night we hear about a new variant, and now there's one being discussed in Southern Africa. There may be a time where natural immunity, where we see on the spectrum of kind of protection, is a bit lower than vaccine-derived immunity, wanes or gets to a point where a variant is able to escape it more. And so, again, it's still worth it to reinforce that immunity broadly, to have as much protection as possible, not only to protect the individual child, to protect the kids around them, to protect the adults around them, and again, to recognize that we're going to have to live with this virus for a while. Vaccines are an incredible tool to help us reduce the risk, and have made my job a whole lot easier as an infectious disease physician. Kids are going to be exposed at some point or another, and we have to make sure that they have as much protection as possible as they go into this.
Okay, terrific. Okay, so we're coming close to the end of our hour, and what I'd like to do is I'd like to ask each of our panelists to provide 2 short 1 or 2 takeaway messages from their perspective. So Dr. Lourenco, I'm going to start with you, then to Dr. Upton, and we'll close with Dr. Chagla. So what are your 1 or 2 key takeaway messages for the audience?
Okay, just wanted to relay that from the regulator's perspective, from Health Canada's perspective, the vaccines have been very rigorously reviewed. We followed internationally established guidelines to assess the safety, efficacy, and quality of these vaccines. And so parents can be confident that the vaccines meet all of those high standards.
Awesome, thank you. Okay, Dr. Upton.
Thanks so much. Yeah, I would say that the way the vaccine is given takes into account that there is a tiny risk of allergic reaction to the vaccine. And so for the vast majority of people, that 15 minutes that is built into the vaccine delivery regimen and the way that it's being given is sufficient and appropriate for the tiny risk of allergic reaction. There is a small subset of people who are being advised for an additional wait, that 30 minutes, and it really is a small group. It is people who have, a suspected reaction to one of the components of the vaccine. It's the people who have prior reactions to injectable agents, and then so those people are advised for a longer wait. And then people who have actually reacted to the vaccine or have a proven allergy to a component of the vaccine, they are in this sort of other group where they really do need to have the opinion of an allergist before they go ahead. And even in that situation, the vast majority of even those people can be safely vaccinated. So it's for the vast majority of people, they can get it routinely with no pre-testing, and the weight that has been put in to protect all of us.
Great, thank you. So in essence, those that are managing food allergy and other allergic conditions, you can have this vaccine in the same way as other Canadians. It's what you talked about in terms of a previous reaction to a component, a known allergy that really necessitates further conversation with an allergist, not to say that it can't happen, it's how it's administered. Okay, and then Dr. Chagla.
And those other situations where there's a longer or an advice for a longer wait. Yeah.
Right. Okay. Dr. Chagla.
Yeah, I would say, look, this is look for good resources. There are great resources through the Public Health Agency of Canada, through the provincial governments. There is going to be a lot of misinformation circulating around these vaccines, but it is an appropriate decision for parents to make, but feel comfortable with that decision. So look to appropriate resources like Food Allergy Canada, the Public Health Agency of Canada, your provincial health authorities, your local public health authorities for evidence-based real data around this. And again, be comfortable with the decision you make when you choose to make it.
Awesome. Thank you very much to our panelists. I'm going to ask you to turn your webcams off, and we're going to just wrap this up, but we really appreciate you taking the time and sharing your expertise with our audience. So let's go back to our poll question. If we can have our audience fill this out. Following this presentation, where are you at on the question of information needed to confidently make a decision? So if people can fill that out. And let's see what sort of answer we have coming up. Okay, so a great change from where we were before. The pre-poll had the yes at 22, we've moved it to 82. We still have some in the unsure and no category, so we would really encourage everybody to fill out the webinar survey that you will get and make sure you help us understand where your questions still sit. So what's up next for us? Well, we're going to continue to update our COVID section on our website, so please look there for additional information that you might find helpful in your decision. Just a reminder that you'll get a short survey through GoToWebinar immediately after this webinar. It'll pop up on your screen. You'll receive it also an email in the next hour. We really appreciate you filling it out. It really helps us understand where the information needs are. So today's webinar is supported by the Natural Science and Engineering Research Council of Canada, the Walter and Maria Schroeder Foundation, the Sean Delaney Memorial Golf Classic, EpiPen, and the Peanut Bureau of Canada, and made possible from individual donors like viewers like yourself. So please, if you could consider and you enjoyed this type of programming, we would be delighted if you would consider a donation today. I'd like to thank everybody for their participation. As a reminder, you'll get a recording of this webinar in the coming days, and we will email it to you, and you can feel free to share that with others who you feel may benefit. This concludes our webinar.